This one's pretty good, actually. Hi, I'm Michael McMullen, General Manager here at Haemoband Surgical. I'm here today for an interview with the founder of the company and CEO of the company, Mr. Issam Gharib, retired consultant surgeon, 35 years. Good to see you, Issam.
Mike, thank you.
Yeah. Firstly, I suppose really the best thing from our perspective is can you explain how the device works?
Rubber band ligation has been used for the last 70 to 80 years, and it has been successful. But it's the way you apply it which has made a lot of progress. What happens here that instead of drawing the tissues into the device to apply the band using a forceps or anything, its suction is used to do that, which makes it easier. And then as well, that we don't have reload because we have 4 bands, which they are automatically deployed, or reloaded. As soon as you fire one, the other one is ready. So that makes it easier, makes it quicker, and that it's very good for the patient actually for shortening the period where the proctoscope is inside the patient.
Once you fire one band, the next band then reloads automatically?
Reloads automatically.
Okay.
You fire one, the other 3, each one of them moves a step forward. And the first one of them will be ready for firing. So sometimes you don't need to take it. If you're using a proctoscope, especially which a bit larger, that you can actually apply the 3 without moving, without taking the gun out. You can apply to the 3. So if it's a small size proctoscope, you apply and then you pull it out to readjust the proctoscope to the second hemorrhoid and then to the third, and you apply.
So yeah, so if you're using a slightly smaller proctoscope, you're then able to then take out the device to have a look to make sure you've done it the way you correctly and the way you wish, and then reapply if you want a second hemorrhoid, apply with a second band. Okay. I understand. I suppose, can you explain how you do the procedure? As you have a special interest, obviously.
Okay. The way I do the procedure is, say, if I'm using our proctoscope, which has a sleeve, and this is the trocar. Obviously, you apply a lot of KY jelly on the 2 of them, introduce it inside. Then you are left with a sleeve, which allows you to put the proctoscope in, and this will allow the operator to move the proctoscope if we have a sleeve like that, so it doesn't cause any pain. And then you can direct it wherever you like. When you see the hemorrhoid, you apply the band to the hemorrhoid. The way I do it is, I apply above the hemorrhoid.
Okay.
So I apply the band above the hemorrhoid. Hemorrhoids are 4 degrees, so bands are used for treating 1st, 2nd, and 3rd degree hemorrhoids. So this is the 4th degree hemorrhoid, which is prolapsed all the time. This one is the 3rd degree, which pops out when the patient defecates, and then the patient replaces this manually, and it stays in. If he does that with the 4th degree, it doesn't stay in. It comes out straight away. Then we have the 2nd degree hemorrhoid and the 1st degree hemorrhoids. What I do is go above the hemorrhoid, which takes me well above the dentate line, and apply above the hemorrhoid or at the neck or even above the neck of the hemorrhoid. Okay. That's where I apply. At first, we thought that applying the band to the body of the hemorrhoid, because the band takes the hemorrhoid and then it will fall off, and that's how we got rid of the hemorrhoid. But this is not the mechanism. Actually, it works. How it works is that when you apply a band to the tissue, it cuts the blood supply, causes necrosis. Necrosis causes irritation in the tissue around and the formation of fibrous tissue, which is natural, and that is formed in the submucosal plane. And when that forms, it contracts. And when it contracts, it lifts up the mucosa. The rectal mucosa lifts it up. Because hemorrhoids are prolapsed mucosa. And that's how it is treated. Okay? And then the good part about it is that you are away completely from the dentate line, so we don't cause any pain for the patient.
That's really good. Thank you. Yeah, I think that's one of those key areas that people talk to me about when I do meet them at the conferences. So and exhibitions. So from your perspective, it's really above the dentate line is the key, and above the neck of the hemorrhoid, or on the neck or above the neck is perfectly fine. So you stay well away from that dentate line, so the patient comfort is nearly guaranteed.
Yes, it is not only, I'm not going at the neck of the hemorrhoids to get away from the dentate line only. No, it's actually, it gives you the maximum treatment of the prolapsed mucosa. In some operations we do for hemorrhoidectomy, like stapled hemorrhoidectomy, it's 5 centimeters up where you put the stitch to lift up the mucosa. So the higher you go up, it's the better to lift the mucosa.
I see. So yeah, so you're ultimately you're lifting up that prolapsed mucosa, and you're doing it in such a way that it's double. Really, it's one is that yes, you're way away from the dentate line, but ultimately you're doing it further up, not so much because of that, but because you get the maximum effect of both of the banding. I understand. No, that explains. That's great. No, that's one of those questions I get quite a lot. How would you advise, I suppose, for people from clinicians who are struggling, who when they place a band on the tissue, that the band almost immediately falls off or falls off soon after? Have you any advice on that?
The first part of that is the amount of tissue which is distal to the band. Mm-hmm. If you have a very small amount of tissue and then the band is applied, the band can slip. But if you have a large amount of tissue and then the band is on top of that, the band will never slip. Okay, so what gives us this large amount? The size of the tip of the gun or the device you are using, because the tissue will go inside it. Now, when we had this gun made first, it was 7 millimeter. That was on the small side, but we increased it to 9 millimeter diameter, and that sucks a large amount of tissue. Now, what brings the tissue inside the tip of the gun is the suction. So you have any problem with the suction, that will reduce the amount of tissue. So the first thing is that on that part of the gun, we call it the Christmas tree, this has to be a tight fit to get all the suction. The suction itself, we recommend 600 millimeter mercury, but even 500 millimeter mercury of suction will be enough. Okay. The wall suction will be enough. It's very good for it. So that's the amount of suction you need. And then when you apply, this was one of the common problems, when you are applying the tip on the tissue, if you apply it too loosely, so you will allow the air to go in, and what happens, you lose suction. If you apply it too hard, you have stretched the tissues around the edge of the gun, and you prevent the tissue from moving inside the gun. So if it's too hard, or you left a space, that's what goes. So it's just the natural pressure of the hand on the tissue, and then squeeze the trigger. There are some surgeons who like to say, okay, I'm going to stop when the trigger stops at the suction part, and that's why you put a mark on the trigger. If they like to stop for a second or two, and then complete the squeeze to fire the band. Myself, I just found that I squeeze the trigger once, and the tissue goes very quickly, and it's applied.
So that's really interesting. So that gives me good knowledge, me personally, but also hopefully for you watching as well. So that question does come up a lot, where some people aren't sure of how much suction they need. But what we're saying now is that yes, 600 millimeters of mercury is our optimum suction. But yeah, I also know other clinicians who use much less, maybe 450 or 500 millimeters of mercury, and they get the perfectly good results that they want. But from your experience, and obviously being the inventor, it's really about not having too much pressure, but also not having too little. Yeah. So it's just touching enough that you've sealed, made a seal, but don't push too hard, because otherwise the tissue is too taut that you can't draw enough tissue. So that's it. So don't be too press too hard, but don't ease off too much also. But ultimately, I suppose from those that are using it, even if you make a mistake with the first band, you have a total of 4 bands on the device anyway. So if they make a mistake with the first one, they have second, third, and fourth bands there to correct the error if they do indeed make one. A number of people ask me the question, and particularly people who have never done banding as a therapy for hemorrhoids, how many hemorrhoids can you treat in the one session?
In the UK and Ireland, we always apply rubber bands on the 3 hemorrhoids without any problem. But in some places, the surgeons recommend apply 1 band because of the discomfort for the patient. I found that the discomfort actually is related because the bands are applied on a tissue which the patients can feel. So it's the length of the procedure. And we got an idea, we looked into the research available, that was there any comparison between applying 1 rubber band at a time and they bring the patient every 6 weeks, applying another one and then the third one, and then bringing them in, see if it worked or not, and or apply 1 band on each one of the 3 hemorrhoids. And was that a cause of any discomfort? We actually did this like a study on 50 patients, different genders, different ages, and we found that in 48 of those patients, we finished the procedure in 2 minutes or less using the Haemoband. And the recorded pain or discomfort, it was in the majority, they said slight discomfort, which you can expect. Slight discomfort after putting a proctoscope in and doing the procedure. But there wasn't really anybody complained of any severe pain, which needed medications or anything like that. So I would recommend really for the patients that we treat the 3 hemorrhoids at the same time.
That's interesting. So yeah, there's different theories and different, I suppose, practices throughout the world. I've traveled quite a bit talking to clinicians, and yeah, everyone has different opinions. So, but from your experience anyway, there's no difference to the patient in terms of whether you treat 1, 2, or 3 hemorrhoids in the one session.
Yeah.
Okay, but ultimately it's a clinician's choice how they choose to treat them. So okay, no, thank you. I think that covers the main topic of questions that I get asked when I'm traveling. And thank you for your time today. No better person to speak to than the actual inventor of the device and someone who's got a vast experience in treating hemorrhoids. So thank you very much. If you have any questions, please put your questions into the chat box, and we'll be happy to answer them for you. Thank you.
Thanks.
Haemoband Plus, the gold standard of rubber band ligation.